So as an overview, we'll start with some foundational principles, specifically like biomechanics and material science, and we're going to break it down into major sections. First, we'll talk about arthrodesis, specifically what kind of rods and screws slash fasteners we've been using, interbody cages and surface coatings for different implants. And then secondly, we'll talk about some arthroplasty techniques and implants that are most commonly used today. So I think this slide is probably like the most important slide of the entire talk, and it's drilled into us as orthopedists from like day one of residency. But I think oftentimes it goes, we kind of are doing this every day. We kind of forget about it, but it's Young's modulus, or the modulus of elasticity. And it's a fundamental mechanical property that measures a material's stiffness or resistance to elastic deformation under tension or compression. So it's defined as the ratio of tensile stress to tensile strain. And that's the y and the x-axis respectively in a material. The elastic zone, which is orange in this picture, is the initial portion of the stress strain curve where a material deforms temporarily under a load and then returns to its original shape upon unloading. Yield strength, which is, you can kind of see on that graph there, is the moment where the elastic deformation turns to plastic deformation. And essentially what that means is that when the stress is removed from the system, the deformation of the material is permanent and it never goes back to where it was before. And each of these materials has different graphs, different stress strain curves, and that kind of, we'll get into that a bit. So this graph illustrates a bit where different common biomaterials fall. Most notably, cortical and cancellous bone are on the lower end of the stress strain curve here, while titanium and PEEK fall closer to the modulus of bone, which improves the in vivo compatibility and reduces the stress shielding, which commonly occurs when there's a modulus mismatch in the body. And most of orthopedic implants today are titanium or carbon fiber, which give favorable characteristics. Stainless steel and cobalt chrome are much stiffer, which is ultimately better for rigidity, like they're stronger materials, but this might cause a mismatch of modulus and cause complications over time. So understanding where each of these materials fall relative to bone helps us predict how they'll interact biomechanically overall. So it's also really important to understand that historically these stress strain curves were graphed with like solid materials being tested. And what's much more relevant to spine surgeons is how newer porous titanium lattice implants behave. And there's a recent biomechanical paper published in 2022 or 2021, sorry, about the variance of Young's modulus based on the porosity of titanium. So this showed an increase of porosity, decreased Young's modulus, which intuitively makes sense. And again, is clinically relevant when determining implants for our patients. So some principles of fusion. So, goals of spinal instrumentation in the context of hopefully obtaining a fusion is to provide enough mechanical stability to a system to promote osseous fusion, bridging of bone. And a nuanced understanding of alignment and patient outcomes has shifted the focus of instrumentation a bit towards improvement of mechanical alignment, with our interbody devices, surgeon-specific rods, different materials. And secondary goals of instrumentation include stabilization to protect neural elements after decompression or indirect decompression of the neural elements via increasing foraminal height and area, interbody work, and also maintenance of alignment to target parameters in an ideal world. So a little bit of a historical kind of around the world here. This is an example of an early rod, which is the Harrington rod, which is made with stainless steel. These rods are offered high rigidity, but were limited in their malleability and failed to mimic natural spine biomechanics. Over time, the field evolved to titanium and cobalt chrome, depending on the balance of stiffness versus flexibility needed in any individual case. So titanium, again, now widely favored in standard constructs, while cobalt chrome is reserved for cases where rigidity is critical, such as deformity correction, and PEEK rods are less common due to their poor contourability. So going a little bit more into some material property of the rods, the titanium, again, is the most frequently used rod material because it's close to cortical bone's modulus and otherwise biomechanically favorable, as we saw earlier in the graphs. It's more flexible than cobalt chrome, which reduces the stress shielding, again, which is the difference of modulus in vivo, and produces less image artifacts, which I didn't know until doing some research on this. Cobalt chrome is also great for maintaining alignment in deformity cases, but it can be more challenging to work with. We've all been in cases trying to get a cobalt chrome rod seated on two lips is a little bit difficult if it's not perfectly bent, which is what the surgeon-specific rods can help with. And PEEK is the most bone-like modulus, but relatively inflexible and doesn't perform well with bending moments, which is why we don't really use PEEK rods. And kind of getting a little bit into the biomechanics of rod bending specifically, we've all bent rods interoperatively. Sometimes a little bit more challenging for us to do it than some of our attendings. Like how they do it so well. But what's important to understanding is that bending introduces notches, usually, not always, again, which can act as stress risers in the system. Ultimately, that can reduce fatigue strength of the rod and increase the likelihood of rod fracture down the line with fewer cycles. So this is a biomechanical study that compared notch versus notch-free rods made from titanium and cobalt chrome. Notch-free cobalt chrome rods demonstrated the highest load to failure strength. And the takeaway here is that pre-contoured or patient-specific / surgeon-specific rods may preserve the strength and reduce failure risk. Switching gears a little bit now to pedicle screws. So this has obviously become a staple of spinal instrumentation over the last couple of decades. And their design allows for transmission of force across the vertebral column, where previous instrumentation used prior to this was mostly just posterior column control. So this aids in deformity correction, provides segmental stability, and the majority of screws used today are titanium alloy due to the favorable modulus and biocompatibility. And key biomechanical variables include bone quality, screw length and diameter, as well as adjuncts such as surface coating of the screws and cementing. So looking a bit at screw loosening and fixation techniques. So screw loosening and pullout remain challenges in spine surgery, particularly in patients with osteoporotic bone that we encounter not infrequently. So different kind of enhancements in screw thread design, surface treatments, and trajectory planning can help. Cement augmentation and surface coatings such as hydroxyapatite or plasma spray can increase pullout strength, as we'll kind of go over a little bit in biomechanical studies. And again, pre-op planning and intra-op flexibility evaluations are critical in mapping this out. So here's kind of one of the oldest historical studies looking at pedicle screw strength and pull-out and depth, all that good stuff. So this is a cadaveric study from the 90s, compared screw depth at 50% of the pedicle, 80% of the pedicle, and 100% of the pedicle. The results confirmed what I think a lot of us intuitively know or believe, is that the deeper screws within an anatomical context provide stronger fixation and increased load to failure. So at 100% insertion depth, the screws had up to 150 greater pullout strength compared to an 80% depth. And every 5 millimeter increase in length added about 26% in strength. So, this, again, maximized the screw length when possible within the anatomic constraints. And there definitely is a time where how strong is strong enough. This study didn't look at that, but it does, again, show us that you get as much depth as you can while being safe. Again, this is looking at a 2015 meta-analysis that ultimately evaluated pedicle screw with cement augmentation. So it said that cement is an effective material for enhancing pedicle screw fixation in both osteoporotic and revision spine surgery models. It also looked at fenestrated screw delivery systems, and it appeared to have some benefits compared to vertebroplasty. It resulted in similar screw fixation to pre-filling with cement with a solid screw. So again, nice little biomechanical study here, reiterating what a lot of us already believe. Again, here's another 2020 study looked at the effects of cement augmentation, specifically fenestrated screws versus vertebroplasty. So compare the two. I know we've seen both of that this year already. So this was a large retrospective study of 241 patients that showed screw loosening was reduced from 50% in the unaugmented group to 7% in the augmented group. Cement leakage outside of the bodies occurred in both the groups, but were asymptomatic. And fenestrated screws had a slightly higher fracture rate compared to the non-solid screw group at only 5%. And interestingly enough, where it said that the screws fractured were at the distal third, or sorry, the proximal third here, which if you think about where fenestrated screws are actually fenestrated, it's the distal third. So I'm not entirely sure how that makes sense biomechanically, but it's some food for thought there. And then we're going to switch gears again a little bit here and just talk about surface treatments. So this was an original study looking at surface treatments of screws in 12 mini pigs that were evaluated for integration with different types of screws using micro CT, pull-out strength, and stripping torque, as well as histological analysis of 1 month and 3 months after implantation. So screw types included smooth surface pedicle screws with sandblasting treatment, and then pedicle screws with large grit and sandblasting, as well as acid etched treatment. The micro CT showed that the gap between bone and implant was consistently higher in the sandblasted only and smooth group compared to the etched group at 1 month and 3 months. And the removal torque and pull-out strength was higher in the group that was acid etched. So again, these surface treatments are showing that bone does have an affinity for them more so than more traditional screws. So this was another study looking at pedicle screw treatment and with hydroxyapatite, and looked at 7 patients with HA-coated screws, half removed 1 to 2 years later. So it showed that HA-coated screws had significantly greater insertion and extraction torque compared to uncoated screws. Some were removed at 10 to 22 months and showed stronger bone integration. However, they were still harder to remove, which can be a challenge in revision surgery. This technology has definitely shown promise, but not entirely used too much in spine surgery, at least that I've seen. I saw it a lot in orthopedics with like X-Fix pins. I don't know if you guys ever used HA-coated X-Fix pins, but not entirely made its way into the spine field yet. All right, so switching gears a little bit more again, we're going to talk about interbody devices. They serve several roles, not limited to like restoring disc height, maintaining foraminal patency, stabilizing the motion segment, and facilitating fusion across the end plates after they're prepped appropriately. Material and design impact how effectively a cage can achieve these goals, especially in cases with compromised bone or alignment. And we're going to kind of go over all the different kinds of interbodies that we use most commonly today. So first, allograft. So structural allografts were widely used, including femoral cortical ring allografts. They provided stability, but did have some issues with graft resorption, donor site morbidity, and subsidence. These drawbacks led to exploration of synthetic materials aimed for improved consistency and biointegration. This is interesting. The femoral cortical ring allografts were described for ALIFs by Dr. O'Brien in the early 1980s. I'm not sure. I actually used this a lot in residency. I thought it was pretty interesting. Here's a study looking at PEEK versus structural allograft in ACDF. So this was a study out of UCSF, a retrospective review in 2019, compared PEEK cages to structural allografts in ACDF with 2 years of follow-up. There was no statistically significant difference in fusion, reoperate, or subsidence. However, they did note that the PEEK was favored for imaging clarity and implant consistency, despite limited osteointegration, which I thought was an interesting study. We use some PEEK here occasionally, and I'll go into kind of when to use each implant or have a gestalt for it. This is another study out of JAOS from the 2020s. This was looking at the effect of cervical interbody cage morphology, material composition, and substrate density on cage subsidence. So they tested 5 factors to assess subsidence. The cage material was a silicone alloy, a titanium alloy, and a PEEK. And they had different substrate densities, which they had low density cancellous, high density cortical, and then there were different footprint sizes, surface textures, and filling. So in low density bones, smaller cages had significantly more subsidence, and this reinforces the value of footprint and contact area, especially in osteoporotic patients. Material seemed to matter the most in poor bone conditions. PEEK and titanium showed higher subsidence in low density models. Rough textured cages performed better, and in a higher quality bone, it seemed that the effect of material and texture was less pronounced when kind of going back and forth between all these different variables. And again, it shows that patient-specific factors can dictate materials performance, and I think we've all sort of figured that out throughout this year. And then, autograft remains the gold standard in terms of biology, but it does have drawbacks, as we mentioned, like donor site morbidity. Allograft avoids harvest issues, but can resorb. And this is kind of where synthetic cages have really kind of come to the forefront, especially PEEK and titanium. They're more consistent and allow for design customization, but may require coding or design enhancement to optimize their biology. And we'll kind of jump into this a bit now. So we're going to look at titanium cages first. Titanium cages promote osteointegration and are biomechanically favorable, but are certainly stiffer than bone, despite having a Young's modulus, which is fairly close. This can cause subsidence and stress shielding, and they also do produce image artifacts, as we've seen getting post-op imaging. Shape and surface features like porosity can mitigate some of these issues, and 3D printing allows for some greater customization, but still, nonetheless, is an issue we face. Jumping into PEEK now. So PEEK is radiolucent and has a modulus that's closer to cortical bone, but this does reduce imaging artifact and subsidence. However, it does tend to form this fibrous interface with a macrophagic response rather than direct bone bonding. This occasionally raises some concerns in the community about pseudoarthrosis or cage migration, but there still does appear clinical fusion across the site that is worth using. And then titanium coated PEEK, which is kind of a newer technology and something that we do see here from time to time. It aims to blend the image clarity of PEEK with the osseointegration of titanium. There still are some concerns about the coating delaminating off of the PEEK and certain wear debris, but overall, it's a pretty low concern. And 3D printed titanium and hybrid constructs attempt to solve the issues. Titanium maybe being too stiff for osteoporotic bone, and PEEK maybe not having as much bioavailability or biocompatibility as titanium. So this is sort of what brought this titanium coated PEEK to the forefront. And then just some general principles about these cages. This is a classic biomechanical study looking at the effect of smooth versus porous titanium with respect to osseous integration. So this study showed that roughened or porous titanium surfaces led to better bone response compared to smooth ones. This was confirmed by in vitro studies and early 3D cage designs in reinforcing the importance of surface topography and porosity on implant biology. And then this is an article out of the Spine Journal in 2018, essentially comparing different cages in 27 different kinds of sheep. They implanted these cages at L2, L3, and L4, L5, and they looked at PEEK plasma spray, force coated, as well as 3D titanium alloy. And they got CT scans at 8 and 16 weeks, and they eventually also looked at flexion extension moments as well as histologic slides. And they found that there's no difference in the range of motion with flexion or extension or lateral bending in the different groups at 16 weeks. They found that that led to the growth, and the on-growth with the 3D cage was superior to the PEEK, which theoretically confers more stability. As mentioned earlier, they all have fibrous tissue surrounding the implant somewhat, but PEEK had a little bit more than the others. And then here's a study looking at titanium-coated PEEK in vivo. So this looked at titanium-coated PEEK in a sheep model demonstrating significantly more bone by micro CT qualitative grading when compared to PEEK alone. And the histology showed newly formed woven bone tracking to the surface between these implants, which again led to higher pull-out strength and sort of showed us that these implants can definitely be used safely. All right, now last time switching gears, talking a little about arthroplasty, we'll start with cervical disc replacement. So as we all know, the goals for these are to preserve motion, reduce adjacent segment disease theoretically, and maintain sagittal alignment. Implants must be balanced, which is certainly can be certainly a challenge in these. And again, with the balance, the patient's biomechanics, biology, and imaging clarity when thinking about all these designs. So this was a lit review, an explanation of current disc technology. Again, there's 6 possible degrees of freedom with rotation and translation on all 3 axes. And implants are further categorized by the number of articulating components that they contain. So the first modern cervical disc arthroplasty was the Frenchet cervical disc, later renamed the Prestige disc, and it was approved by the FDA in 2007. It was a stainless steel ball and socket design with end plates secured by screws. The most recent iteration, the Prestige LP, is a titanium ceramic composite with porous titanium coating to promote ingrowth. And this was approved for 1 level in 2014 and 2 level in 2016. So now kind of a little bit more about maybe what we're using today. Implants are classified, again, by the number of components that I mentioned. And newer 3-piece implants, such as the Simplify and the Mobi-C, allow for more motion, theoretically, where the 2-piece options, such as the ProDisc, offer more stability with a fixed core. And again, the choice depends on clinical goals and anatomic factors and what we're comfortable with instrumentation-wise. I think what's important is that the Simplify, as we've seen postoperatively, has the least amount of MRI scatter, which can be very important and clinically relevant for patients with follow-up imaging that's done not infrequently. Um, and then the Protisc C is made of cobalt chrome with roughened titanium end plates. With roughened titanium end plates, you have to promote bony ingrowth, and with the core being ultra high weight molecular polyethylene. And here are just some other two component discs. The Protisc C, the Discover, which I don't think I've ever seen. The Cervicore disc, Prestige, which is used not uncommonly, and then some other implants that I haven't seen before, such as like the Tridyme C. Interesting looking. And then lumbar disc arthroplasty, the first was described actually in 1950 with the implantation of a stainless steel ball in place of the nucleus pulposus, and the X-ray is kind of fun to look at. Just looks like a marble in there. In 1980s, the first commercially distributed TDR was developed, and it utilized technology developed for total knee and hip prostheses. And the implants consisted of a sliding polycore between two metallic end plates. And this implant's gone through 3 generations with variable success, not done as commonly. The ProDisc L, which I think is probably the most commonly used lumbar disc arthroplasty today. Um, Similar concept to the older designs, except for polycore attached firmly to inferior end plate with a locking mechanism, and only articulates at the superior end plate. It utilizes a blade for vertebral fixation instead of spikes. And the Maverick, which is another commercially available device, which I haven't seen, but is available, is metal on metal design with cobalt chrome end plates and bearing surfaces. And I think a lot of it's the metal on metal concerns with previous total hips definitely play a role here too. So there's definitely a lot and kind of an overview on everything we use, but I think a summary is understand what implant choices we have and definitely be thoughtful about how we're using them, specifically in patient specific, like how to be patient specific with these in certain circumstances when the resources allow. For example, patients with osteoporotic bone, will their bone be strong enough to handle the titanium interbody? Is PEEK maybe a more reasonable choice for these patients? If you're using rods, will cobalt chrome rods overpower the weak bone? Maybe titanium is a better choice. And again, understanding the pros and cons of implants in the market and just making informed decisions as we go. And that's all I got.
Nice.
That's great, Ryan.
Nice job,
We throw this lecture in there because we believe it's really important. It's important on a bunch of levels, but I think in spine it ends up having a little bit more relevance than in other parts of orthopedics. Just because, and I would say neurosurgery, because of that, all the different factors that you outlined. So just realize that most of the time we're making choices based off of some scientific merit, maybe not necessarily always evidence-based, but a lot of times you don't have that. We don't have the luxury of understanding all the patient-specific requirements and all the implant variability that we have. So being able to think through that, I think, is really, really important. So great job outlining that for us.
Yeah, I think you guys
Questions
probably
for you
don't realize
guys?
this, but yeah. I was just gonna tell them, like, you guys probably don't realize this, but you have such an advantage by being here and even giving this lecture and like listening to these guys and what they use and why they use, because other places this like doesn't even get talked about. Like there's a cage that they've used and a type of thing that they've used, and that's just how it is, and there's no kind of discussion about it. So I think that as you guys get out there, you're so much more knowledgeable about this stuff than anybody else. So use that to your advantage and pick and choose wisely, and it also gives you an ability to get involved with industry and things like that. So
I'm gonna add one more thing, not to get on the bandwagon too much, but think if you're thoughtful about every implant you choose, it'll make you it'll allow you to choose more wisely for your patient, but it also allows you to interface with the value analysis teams, the care lines, because you're going to be having to champion technology that's to your benefit, your patient's benefit. And if you know it at a scientific foundational level, you'll be able to advocate more effectively.